So how you holding up, Holly?
We're hanging in there, Denise. How about you?
Good, thank you.
Good, good. We're doing a lot of legislative advocacy work, that's for sure.
Yeah.
While we wait, let's see. Does anyone else have any announcements that they would like to make? We usually do those towards the end, but since our first speaker presenter, Erica, is having problems with her device, and we're waiting for her to check back in. Oh, thank you, Lynn. Great. Yeah, the meeting tonight for OPS is a really great speaker. So we're going to try to sign off right at 8 o'clock so people can join that. It's supposed to be a really, here she comes now. It's supposed to be a really good meeting.
Yeah, I had seen a presentation that Dr. Jarvis did with Whole Washington maybe a year or two ago. And he has really incredible talking points to talk to conservative legislators about. Not that they're really listening, but it kind of betrays that they're not really conservative when, because they start defending how this system that costs more is something that's, better than something that would cost less. So, but it's very worthwhile.
Okay. So Rana, would you like to have an introduction for Erica, or Erica, you don't have an introduction for us?
Well, I have a very brief one.
Okay.
On the PNHP website.
Okay.
So Dr. Erica Hyman is a general internist and current fellow in addiction medicine at Yale University. Previously, she was an assistant professor at Emory School of Medicine in Atlanta, Georgia, and she has been involved with and supportive of PNHP pretty much since med school. And more recently, she's become kind of the facilitator of the Connecticut branch of PNHP. So welcome.
Thank you so much, Rana. And that's a great introduction. You even pronounced my name right. Like that's more than I could ask for. So I'm actually a recent transplant to Connecticut. I've only been here a little under a year. I was living in Atlanta, Georgia for about 6 years before that. And prior to that, I was in California. And I've been a PNHP member, sometimes more active, sometimes less active for that whole time. And have enough experience to know that we're making things hard on our patients and our doctors and our other providers as well. But having been to, in particular, a state that didn't expand Medicaid, and just seeing how many people are going without any coverage and what that does to not only individuals, but their communities, their children, and it really spreads so many ripples through the community, through cities and states, that it's really unbelievable. And obviously expanding Medicaid is part of a solution, but it's not enough. We still have people on private insurance who lose their jobs and then are left in the dust, and so many other situations that I know you all are familiar with, that are really symptoms of this giant problem we have with healthcare in our country. On the provider side, it's often difficult to feel like the work you're doing is fighting against a system that is not set up to help people. So it really, I think, leads to a lot of burnout on the physician side. And That's been clear to me for a long time, and I think a lot of people I work with recognize that as well. And so part of being active in PNHP for me is kind of making sure that my medical community and other communities know that we're active, we're here, we're speaking out and saying like this change is necessary, this change is possible, and look at the rest of the developed world, and things could be very different and could be much easier and more moral. Really, it's the immorality of the system that is what keeps me motivated and fighting. So yeah, I don't know how much you all know, probably more than I do, about the reintroduction of the two bills that are national Medicare for all bills. And they, yeah, Phil says the irony of the state that is home to the CDC is a state that refused to expand Medicaid. Yeah, it is. And I worked with a lot of CDC people and a lot of infectious disease people, and they're the most like liberal progressive people there are. And so it's just totally mind boggling that all exists in the same state. All right, so the reintroduction of the national Medicare for all bills, there's going to be one in the House, one in the Senate. Similar to last session, the House bill is going to be introduced by Pramila Jayapal, the Senate bill by Bernie Sanders, and they're doing a joint reintroduction, like press kit and all that, on May 16th, and a press conference on the 17th. So we're really making a push right now to get our legislators signed on as co-sponsors. From what I know right now, I don't think Connecticut has anyone who said that they are going to be a co-sponsor. The people in the past who have been co-sponsors were Johanna Haynes on the House side and Richard Blumenthal on the Senate side. And I have not really heard anything about whether they've committed to be co-sponsors this time around. So definitely they could use phone calls and outreach from their constituents. We're really asking everyone, PNHP leadership and other organizations are asking for everyone to make calls as citizens. And then I think it might be worth it for some of the organizations working in the same area, like Medicare for All Connecticut and PNHP Connecticut, to write a letter together and send them to our legislators to ask them to be co-sponsors. And I don't know if that's something you all have talked about beforehand or thought about or have experience doing. Has anyone contacted their legislators to ask them to be a co-sponsor?
Not
Not
this
during this
year, I
session.
don't think, but in maybe in 2019, I think we collected a whole lot of signatures and and had a meeting with Johanna Hayes to get her on board. I think Richard Blumenthal was kind of on board from the start, but I'm disappointed to hear that he hasn't committed yet, because at least he speaks about being very supportive.
Yeah, and then we also had a meeting with Rosa DeLauro's healthcare policy staff liaison around that time, who was very canny about whether or not they, Rosa would support Medicare for all if it came to a vote. She has her public option alternative, Medicare for America. I don't know if she's reintroduced that since, but it's kind of, they just point to that in lieu of saying anything definitive about single payer.
Doesn't Rosa get money from the enemy anyway?
I do think she gets
Yeah.
some. I don't think it's like the core of her
It may not be, but
fundraising
she-
base, but it's more than nothing. Yeah.
Yeah. But I do remember signing some stuff, and I don't remember how far back, but I remember mentioning it at something where I actually met Blumenthal. And he talks a good thing, but
Well, Blumenthal was a co-sponsor of the 2022 bill that Bernie Sanders introduced.
True.
So
Yeah.
I am pretty hopeful that he'll repeat. I think with Rosa, one of the issues is she has very strong union support, and ironically, unions aren't necessarily in favor because a lot of union contracts give people healthcare coverage that they feel will be better than what they would get under Medicare for all. So it's not a given that she'll support it.
We've talked to a lot of unions who do not feel that way. There are a lot of unions, believe it or not, that are for a universal single payer because their bargaining is always goes to the medical portion first. And that's the first thing that everybody goes to instead of wages. And that's what's important as well. So it's usually the first thing that is on the table, basically, and that's the first thing that they lose. So if they're supportive of single payer, which a lot of them are, I know the union at Yale is, I believe, and 1199 is. I've talked to several people on 1199, and they're supportive. So they are coming around, believe it or not. And we've talked to obviously the nurses unions. So we have actually talked to several different unions, and they are for single payer. So it is kind of surprising that that notion that unions are completely against single payer is still out there, because it's not always the case. Is that what you wanted to say, Sarah? You're still on mute. Can you not come off mute? That's okay. I just really would love to hear what you had to say.
Yeah, no, I was just, as a union member from Yale, though I'm retired now. Yeah, I was, kind of disappointed in the way things went down with Unite here back in 2020, was it, or 2016? I lose track of them now. But, Unite here did try to persuade their members in Nevada to not, vote for Bernie because of the issue of the healthcare. They sent out a letter to all their members. They worded it very, oh God. Oh, no God. Oh my God. Oh my God. Can I call you right back?
No, probably, but just wanted to.
Your car warranty is about to run out. Quick, renew it before it's too late.
I
You're
muted
back
you,
on mute, Sarah.
I muted you, Sarah, so we didn't hear
Okay,
your
good.
personal conversation.
Yeah, sorry.
That's okay.
Anyway, try to be succinct. I was disappointed in that. Maybe they have changed direction. I would hope that they have. Their members refuted them, so hopefully they got that message. And I don't, I'm out of touch with it right now, but that's just the one piece of experience that I have. But yeah, I mean, it's wonderful to hear that unions are coming around, because it's exactly as you say. They spend a whole lot of time arguing to keep, even to hang on to their health care. And they could be arguing for so many other things, a voice in the workplace amongst many others, and lots of other things, even amongst wages. So yeah, so that's good to hear, and I hope that continues. Yeah.
Yeah, I mean, I agree. I think building coalition with unions is really powerful. It's, yeah, I don't know if that's something that we can work on in the next, week before this bill is introduced, but definitely as an ongoing project, I think that would be great to be trying to form more kind of more formal coalitions with local unions, and then be in contact with our legislators.
That sounds like a plan. Thank you. And we also did have Senator Blumenthal come, and he was our keynote speaker at one of our like, we had a town hall, and he was the keynote speaker, and he is very supportive outwardly for single payer. So we'll have to, you know,
That's great. Yeah, I think the list is incomplete. I sort of got some information from the national office at PNHP, and it was a very short list of only House co-sponsors. So my sense is that we just don't know all the information, and fingers crossed that he is actually in support of it. Yeah.
yes, let us hope. And we will do outreach, and you know, I'm already doing it anyway, almost on a daily basis. So what's one more, you know, one more ask when talking to legislators? Not much. So thank you. We will do that. Anything else, Erica, that we can sort of?
I don't have anything right now, but definitely, and I know there's a lot of overlap between our groups, so I know we're already kind of working together, but we should continue to, you know, discuss what we're all working on so that we can help each other with these projects. I know sometimes getting numbers is difficult, definitely for gathering physicians. It's sometimes physicians and other healthcare personnel, it's pretty difficult to have them lend their time. So sort of filling in gaps and helping each other when possible would be great.
Okay. We will
The
do
only
our
thing I would
best.
just add is to ask Erica to share when the next PNHP Connecticut meeting is, because it is coming up in a couple weeks.
Yes, thank you so much for reminding me. It is May, hold on. May 22nd. So it's a Monday night at 6. And I'm going to put my email in the chat here. And if you want to join us, you are more than welcome. Let me just get it up here. Yeah, I see someone saying National Nurses has started contacting Congress. I had seen that as well. Lynn, if you're involved in National Nurses United, I'd love to talk to you or talk to your contacts, because in Atlanta, we had a really active member of PNHP who is also in an NU, and it was really great to have her part of our group. So it would be really great to work together.
Yeah, what they're doing in California is they're assigning district leaders, and that person tries to get co-authors for both the state and federal bills. Unfortunately, my Congresswoman Anna Eshoo, who gets a lot of money for insurance and pharmacy, is the chair of the Health Committee, and she's been anti-single payer for 25 years.
She's, yeah, I know her name, somewhere in the peninsula, right?
Right.
Yeah.
Well, we're kind of mid peninsula. Yeah, I'll take your email and send you, because there's a meeting coming up. I've been attending those meetings. I think they have a pledge form for Congress. We have a pledge form for state legislators, but I think there's one for federal. I'll look into it and send you the info.
Great. All right, well, thanks so much for having me. I think I'm going to jump off so I can help put my preschooler to bed.
Oh, very nice. Thank you so much for being here, and thank you for the information, and we will keep trying to work together for sure.
Sounds good.
Thank
All
you so much.
Take care, everyone.
See you.
Bye.
Bye-bye. So Does anyone have any questions before we continue on? Any comments? So they did postpone it for one more day till the 17th, as Erica had said. So the sooner we can contact our legislators, the better, because that's only, oh my God,
Next week.
8 days away. And yeah, definitely we need to hear Senator Blumenthal's answer, because he did say he is supportive, but we want to hear that as a yes again. Make sure he gets on there.
Can you
And
say to both Senator Blumenthal and Representative Hayes that if they sign on, they can be our speakers at our next month's meeting?
they sure
be
can.
what?
They could do whatever they want.
Yeah.
Does anybody
They-
have any contacts with the Connecticut Nurses Association?
I have my niece who is becoming a nurse, and I have my cousin who is a nurse now
Okay.
officially. So I'm working on it.
They're having their Nurses Day legislative breakfast and Capitol event on the 17th of May. Speaking of the 17th of May.
Mm.
And if we had a contact, it'd be good to reach out to them to get them to encourage our federal representatives to support Medicare for all.
That's a great idea. Thank you, Phil.
Mm-hmm.
Okay. So I would like to ask the wonderful Sheldon Taubman to please give us our update on our exhausting session and to talk about Husky C and what we're doing to continue to fight for that to be fixed, to stop discriminating against people with disabilities and older people in Connecticut. So Sheldon, the floor is yours.
Well, I don't want to be boring for people who already heard me talk about the subject, so I'll try to make it brief. So this is a consequence, the situation we're in is a consequence of the really, really good parts, or some of the really good parts of the Affordable Care Act. One of the things about the Affordable Care Act is up until then, the Medicaid program was this really rigid categorical program. Only the worthy poor could get health care. No matter how poor you were, can't get health care. You have to be either a child, a caretaker relative of a child, or you have to be elderly, 65 and older, or disabled in the strict Social Security definition of disability. Oh, one last group, pregnant. So that's it. Those are the worthy poor. The rest of the people, you could have zero income, zero assets, be homeless in the street. You do not get medical coverage. So one of the things that the good people pushing for the Affordable Care, I know that there's people in this meeting would say, yeah, but that undermined the effort for single payer. Fully aware of that issue. Nevertheless, in terms of getting access to healthcare for people, they said that's really a problem, this categorical thing. We should just do it based upon income. Just being poor, that should be it. And of course, there's a caveat about, well, what if you're not legally present in the United States? So we won't talk about that, but that's still a problem. Anyway, they said we're not gonna have any categorical rules anymore. So anybody, any adults who are low income, and regardless of assets aren't going to be relevant. Anybody who's low income can be on the Medicaid expansion. And the Medicaid expansion was up to 138% of poverty. And the only people excluded from this expansion were people who were over 65 or who were under 65 and on Medicare. And the people who are under 65 and on Medicare are people who qualify for Social Security disability insurance under that same strict standard, right? And then they start getting Social Security disability insurance cash payments. And then there's a 2-year waiting period. There's some medical conditions that are accepted, basically 2-year waiting period. After 2 years, you then go on Medicare. So the folks who designed the Affordable Care Act, negotiated the Affordable Care Act, what they said is, well, we don't have to worry about those people over 65 and the people who are on under 65 but on Medicare, because either of them have Medicare. So we don't have to worry about that. Let's focus on the other people. And that's what they did in the Medicaid expansion. I think you all know the Supreme Court did a terrible thing and said that, yeah, well, that Medicaid expansion is unconstitutional as a mandate. And so they, by fiat, turned the mandate in the statute into an option. And that's where all the problem has come in these red states, like just mentioned, Tennessee, that adamantly refuse these Medicaid expansions, even with 90 cents back from the feds on the dollar, which is a fantastic deal. And any governor who doesn't take that deal is hurting their own people, doesn't matter. So 10 states haven't done it yet, but most states have. Connecticut was actually the first adopter in the country to do an early expansion. And then we did the full expansion in 2014. So what's the problem? The problem is that Medicaid is better than Medicare. Sorry to say, folks, it's a lot better than Medicare. Should be changed. We need to make, as some have said, Bernie has said, we need expanded or improved Medicare for all, right? But right now it's not. So just some of the things that are not covered include, that are covered under Medicaid include dental, vision, hearing aids, medical transportation, a lot of durable medical equipment. But perhaps the biggest thing is home care services. So basically, Medicare, with very, very limited exception, does not provide home care services and absolutely provides no coverage for what are called PCAs, personal care attendants, who are more flexible than just like a home health aide or a visiting nurse. And that's where predominantly the effort to expand access to home care services so people don't have to go to nursing homes is focused on PCAs. Medicare does not cover PCAs at all. So the problem about that assumption made by the drafters of the Affordable Care Act, that they've got Medicare, so they're all set, is that it ignored this distinction. And as a result, what we have is different Medicaid programs or with sub-programs in each state. And the program for elderly disabled under Medicaid has extremely low income and asset limits. Remember, there is no asset limit for the Medicaid expansion in Connecticut called Husky D. And there's no asset for the family Medicaid program called Husky A. But Husky C, which is solely for people who are elderly or disabled, has an asset limit, and it's terrible. $1,600 savings, $2,400 if you're a couple. And the income limit is the lowest of any Medicaid program. It's not even the poverty level. It's 97% of poverty, which is currently $1,182 a month. So there's this real discrepancy between the income and asset eligibility for people who are elderly disabled trying to get to Husky C, which is the only program they can be in, versus Husky A and D, which have much higher income limits. I should have said Husky A parents is 160% of poverty, and zero asset limits at all, no asset limits, whereas the Husky C people are subject to that. Also, it's fair to say that people with disabilities, older, tend to have higher costs. Is QMB, is Husky C? No, QMB is not. That's a, let me finish this and I'll explain that. It would be okay, maybe, if Medicare filled in the gaps, but Medicare doesn't for so many areas like I just mentioned. And as a result, you have people, I was saying that people who are elderly or disabled have higher costs just by virtue of needing help with certain things, right? You got to pay for certain services that people can't take care of themselves. So in general, their costs are higher. But putting that aside, it's just a blatant, direct, express discrimination that you're not disabled or elderly, your income is this, and sorry, you're elderly or disabled, your income is level is this, and sorry if you're in between there, can't help you. And that gap is between 1182 for the Husky C program income and 1677 for the Husky D program. So what we're trying to do is equalize this by increasing the Husky C income limit to match the Husky D limit. And by the way, whenever you raise a claim of discrimination, there's always a danger that the other side responds by screwing everybody, right? Oh, we'll equalize it. We'll take away from the other group, and now you're treated equal, no complaint, right? The good news is they can't do that here because under the Affordable Care Act, 138% of poverty is the requirement. There are 2 states that got waivers from that, but in general, and the Biden, that was Trump. It's unlikely the Biden administration would do that again. So it really is 138% of poverty. They can't do anything about that. They're stuck with that. Also, federal law prohibits asset limits in the Medicaid expansion. So it's okay to talk about discrimination without worrying they're going to fix it that way. But we have to get them to bring it up to be equal. And we've asked not to get rid of asset limits entirely, but to raise them to 10,000 for one and 15,000 for a couple. This is a very reasonable change. And we did get a bill out of the Human Services Committee that fixes it entirely. That bill did not survive the Appropriations Committee. The Appropriations Committee did keep alive a bill which partially fixes it. It raises the income limit some of the way, but still has discrimination. Raises the assets a little, but not the 10,000 and the 15,000. Fundamentally, the real problem at the end of the day is that the governor of Connecticut is joining with the Republican leaders in saying we will not mess with the spending cap. And I think people know what spending cap is, right? You don't need a primer on that. You don't. Okay. So the spending cap is basically an arbitrary limit on spending independent of how much money you have. So right now, the state government is really, really flush with cash. And the reason for that is mostly ARPA. So all the federal money that came in, really 2 rounds of congressional funding, but a lot of federal money came in. So we're doing really, really well. We've got tons of money to spend. The problem is we can't spend it because of the arbitrary spending cap, which is a formula based upon how much you spent last year. So basically, it doesn't matter that your expenses have gone up or inflation has been tremendous, which of course it has been. It doesn't matter. It's an arbitrary calculation based upon a certain formula, and that's how much you can spend, period. So it doesn't matter that you have real needs, and it doesn't matter you have the money already without raising taxes to cover those needs. You're not allowed to spend the money. And what the Democratic leaders, which is to say Senator Looney and Speaker Ritter, have been publicly calling for, supported by advocates like us, is that they push to, there's a variety of ways to work around the spending cap, and all of them require approval by the governor. The governor has to agree to it. Gee, he's a Democrat, they're Democrats, shouldn't be a big deal. Wrong. He's been made clear he's adamantly opposed to it. So that's sort of where we're at. We're trying to, we as part of a much larger group are trying to push the governor to fund all, not just Husky AC and ending the discrimination there, but other things in order to bring us to a place where we can actually spend the money we have to cover these basic needs. Does that answer it? Oh, I didn't, the question that was in the chat, I think Holly may have responded, but basically the QMB is, which stands for Qualified Medicare Beneficiary, is one of 3 Medicare savings programs. The Medicare, that's the proper term, Medicare savings programs are Medicaid programs, but they're not the Huskies. And what they are is just a limited benefit program which covers cost sharing, some cost sharing under the Medicare program, right? Medicare has co-pays and deductibles and co-insurance and premiums. And there's these 3 Medicare savings programs, the most generous, which is QMB, and QMB covers the Part B premiums, which are, somebody knows a figure, like $163 a month. So it covers that if you're low income, and it covers your co-pays, your deductibles, your co-insurance. The other 2 Medicare savings programs for somewhat higher income people just covers the Part B premium cost, doesn't cover the other cost sharing. So that's all that gets you. It does not get you any coverage whatsoever for something not covered by Medicare at all, like dental, medical transportation, PCAs, and all that. So unfortunately, that's a good program, and we of course encourage our folks to be on it, but it doesn't solve the problem of lack of access to services that are covered under Medicaid that are not covered under Medicare.
So yes, please make sure if you see action alerts coming through that you do send the emails, make the phone calls. It's very important that we do this. You know, for the most vulnerable of our populations, come on, it's ridiculous. It's so just sickening, the things that they're not allowing to happen and to go through that have passed through committee. You know, it's frustrating, but people like Sheldon and others who thankfully are still there to keep us pushed up and going. I swear, seriously, Sheldon, you do inspire me to keep going because I'm still a baby advocate, I feel. And you really do. You really inspire me to keep at it and keep going because I respect what you do. And I really, it's such an honor to know someone who just keeps pushing and pushing and pushing to make sure change happens. And I truly thank you for continuing to do this because I don't know how you do it. It's such a hard thing to keep doing.
Well, thank you. And one of the things that's hard is that sometimes what we're doing is we'd like to improve things, but sometimes what we're doing is trying to prevent harm, damage,
Yes.
like worse things, right? Like that Holly knows all about, the push in many health policy circles to push financial risk onto providers, to make providers have skin in the game for the cost of their patients' health care in order to encourage them to be cost conscious in what they prescribe because it comes out of their pocket. And that's like a really big problem. And that is a threat to healthcare for all of us, particularly for low income people who don't have other options. They just can't, the doctors aren't being helpful because it's coming out of their pocket. So you go somewhere else, you just pay out of pocket, whatever. That doesn't work for low income people. So we have real issues with basically attempts that could worsen access, as opposed to the Husky C discrimination thing, where we're just trying to, we are trying to improve things, trying to improve access. But at the same time, that I joke a lot that in advocacy circles, we learn the oath, which is do no harm, which of course is a joke because it's only medical people get that training. But it's true. I mean, that should be, or my opinion is that should be our number one motto, which is do no harm in advocacy. Make sure that nothing gets worse. Okay, let's do that. Now, let's see if we can do some improvement too.
And remember, guys, the quote or the saying value-based payment model is capitation. It is not the pretty words that it sounds like. It is not value-based at all. It is not. It is based simply on, like what Sheldon said, puts the financial risk on the providers, and there's nothing valuable about that. It takes away from us. It takes away from people with disabilities or complex medical conditions like myself. It's nothing. It's bad. There's a lot of bad out there that we're trying to quell. So just hang in there. And if you see action alerts come through, please don't just disregard them, because we really are trying to stop some very bad things from coming and happening. So trust me, it is, like I said, this session has been exhausting, and it's all good because we're fighting the good fight, but it has been long and exhausting, but we are trying. So thank you, Sheldon. I appreciate you so much.
You're quite welcome.
Well, I have one comment and one question. One, I've been observing and joking kind of that I feel like we're in like the Empire Strikes Back kind of place in our country's, I don't know, development, because it seems as though, as Sheldon and Holly pointed out, we're spending so much time trying to keep things from moving backwards and not really enough moving things forward. My practical question is, since we're coming up to the middle of May, when does the session end? And does that mean we have to have a major push now for over the next few weeks?
Sure. So the session officially ends on the 7th of June. The word is that they intend to finish the budget, which is the biggest part. There's other things, but the biggest part is the budget, and they intend to end that on the 27th of May. So you see, not much time left. And the intensive negotiations are really happening starting now. Like now. This week, next week, maybe the week after. And so some of the things that are happening is that on the 17th, a group called Recovery for All, I'm not sure if any of you are familiar with Recovery for All, is holding a big rally at the Capitol, which the message of which is, Governor, release the spending cap or agree to these various techniques for working around it so that we can spend the money we really already have. And a letter has gone out or is about to go out to him about this, inviting him to come to the rally. Because if he doesn't do that, we're all screwed. And it's not just this area, but other areas as well. So I would say it's happening really fast. We'll see alerts, I think, in the next few days, in the next couple of weeks. We're going to be doing one on House DC. At this point, it really is all about contacting the governor. Yes, you contact Mooney, you contact Ritter, but really it's about the governor. He's the one who is the obstacle. There's a time limit for spending ARPA funds and then you lose it. Yes, I think that's true, but I don't think that's really a problem for where we are, because money is fungible. And so basically they spent the ARPA funds where state funds would have otherwise been spent, right? So it's not, I don't think that's been a problem with not spending the money we have. But the result of that is that we're way, way better off than we were. Now, if you listen to the Republican leadership, they have a completely different story. They say that the reason we're in such great shape has nothing to do with that. The reason we're in such great shape is we have these guardrails like the spending cap and other things. There's other guardrails, and that those things limiting how much we spend, that's why we're in such great shape. It's just really not true. It sounds good, but the real story is we got a lot of extra money we were not counting on. And so that's why we're doing pretty well.
Pat, did you have a question again?
Well, I guess what's going on is I'm trying to equate it with what's going on in Hamden right now. Hamden has $15 million of ARPA money, some of which must be spent in 2024 and some of which must be spent at some date in 2025. And they're busy trying to allocate. Well, they're in the process of allocating it. They've pretty much allocated all but 2.4 million of it. And like they're not allowed to use it to lower their how much they have in their operating budget. So they're not allowed to use it for that. So I'm wondering, is the state using this to fund operating things because they're not supposed to?
My understanding on ARPA, it wasn't so much they couldn't do that, but they can't cut taxes.
That's
with
it. Yeah.
Yeah. And I don't know, as I'm sure you're aware, the governor proposes to cut taxes, and he sort of basically bullied everybody else, the Democrats, into say that, yeah, they want to cut taxes too. And they're, proposing a lesser of a cut. And of course, the Republicans are really pushing for cutting taxes. So I don't know if that really does present a problem with the ARPA funds. I don't know the workings of that.
Because
well
I know
enough.
Hamden got in trouble because they screwed something up as usual.
Yeah,
and
that
they
you're
got
not
caught.
supposed to do, but is take the money in order to cut taxes. But maybe with the passage of time, it's different. I just don't know those rules, so I shouldn't speak on it.
Thank you.
Does anyone else have any questions or comments or? I would really just like to reiterate again, please. I know that this time of year, your inboxes could get slammed with stuff, but I please beg you not to just get rid of them or delete them. Please, if you see an Action Network alert or any action alert from any of the nonprofits or anything like that, please look through it and take action because it's important. And it really does make a difference, especially if you follow it up with a phone call. I know that if you change the first few lines of the emails that we send, I know that a lot of legislators will pay attention instead of just looking at the blank email, you know, like the standard. If you change the first few lines, people will pay attention. But yes, please do pay attention to those. It really is important, and I'm not going to not continue to say that to you probably for quite a while, until June 7th, probably. It won't be until our next meeting, but please, yes, in the next coming weeks and days, pay attention and please get more active and contacting your legislators. And if you know anyone, even if they're not yours and you have good relationships, please reach out and have conversations. And definitely please reach out to your federal people to please be co-sponsors of the federal, Medicare for All acts that are coming out on the 17th. I apologize, my allergies are really bad today. I wanted to say that we are absolutely still looking for someone who would be interested in doing some organizing. You know, we get paid in gratuity here. We don't get paid in money. We're completely volunteer organization, and Pete has been amazing, and Rana has been amazing, and it, you know, we
And
share.
Holly.
Oh, thank you, Rana. We share the duties amongst us, and we would love to have some more help, and we would appreciate some help. So please do email us info@medicareforallct.org, and we would love to have some more help and assistance. So please feel free to join us. And again, I thank you all for being here. And if you have anything else we would love to talk about, that'd be great. But I know the OPS meeting is starting soon, and that's a very important meeting as well, with a really great speaker who tells you how to speak to conservative legislators about single payer. And I know that Rana did put it in the chat before how to register and attend that meeting. So that would be a really good meeting to attend if you would like to. I'm trying to search for it now to put it up again. Oh, there we go. Copy and paste. So please do feel free to attend that. It's really good. He's a very good speaker. If anybody else would like to reach out, again, feel free. info@medicareforallct.org, and myself or Rana will get back to you. And I hope you guys have a wonderful evening. Thank you, Sheldon, for being here. Thank you all for being here, and I thank you, and have a great evening, guys. Take care.